Great, thanks for the introduction. And I'm really honored to be here with you this morning. You know, this is it's so great to see this intersection and to know that you've been doing this for a while now, that the intersection of the AHSNs and the NHSX and the digital with Hugh McCaughey's improvement all coming together, because I'll get to this right at the end of my remarks, but it is actually at the intersection of the improvement methodologies, digital structures and enablement, and innovation that will be the engine that addresses the NHS's highest and biggest challenges. And that is the pandemic recovery and our capacity issues, as well as the health inequalities that the pandemic has shined a spotlight on. And so I just want to say it is it's terrific to see this joined up work, and I am going to do everything I can to increase the amount of joined up work. So have us working together more, less in individual silos, and more working together to address this country's biggest health needs. So on our priorities, so it's most important for those who are creating and interested in innovation and change to understand what the highest priorities are so they can focus their efforts on those. And there are lots of different ways of saying this, but I'll boil it down to just two, which is recovery and inequalities. So on the recovery side, you know, I don't have to, everyone is on this call is very familiar with the recovery issues, but I do want to just go back a little bit historically and say that the capacity issues within the NHS have been simmering for quite some time. Actually, it's been well known that the volume of referrals from primary care into secondary care were starting to back up. It was well known that in the winters, it's called winter pressures, right? That the hospitals filled up with medical patients, and that forced the cancellation of elective surgical procedures. So every spring, and increasingly over the years, there was a backlog of elective surgeries that then were worked through during the summertime, only to be built up again during the following winter. But you add the pandemic to that, and the pandemic highlighted several things, and probably most importantly is that the hospital congestion has become much more severe, to the point where the hospital congestion for medical patients last August and September was worse than in any previous winter, highlighting the significant stress that the hospital bed capacity was under in this country. That in turn was actually and continues to create a backup in emergency, but both conveyances from ambulances and in the emergency room, which itself has created some critical incident situations across this country. This is not a good situation, right? Now, there's a whole lot of thinking that's been going on and needs to continue to go on about how to address this situation. Of course, there are some structural things, just creating more hospital beds, and there are efforts to do that. But but those are relatively long-term solutions. And I think the audience in this forum is going to be with me in thinking, you know, this is actually an opportunity. It's an opportunity because of this pressure. It's an opportunity for us to figure out how to do things differently, how to do them better. And you're going to be spending the day today speaking a lot about home hospital program. The home hospital program, or hospital at home, or virtual wards, or anyone, OPAT, all of those, everything that you can do outside the hospital safely and effectively for patients. If you can demonstrate that what you're doing for that patient is actually reducing the pressure on the hospital, then you've done two things simultaneously. You've provided more comfort and care to patients who honestly would prefer not to be in the hospital appropriately, and to very high satisfaction. I did start and run several hospital at home programs in the United States before coming here, and so I'm very familiar with the extraordinary patient satisfaction that these programs have. You know, I'd much rather be at home with my family, with my family's cooking, and comfortably in my own bed than in a hospital if I could possibly avoid it. I think all of you would share that. The question is, how do you do that in a way that is certainly effective and safe? So you have to be careful about how you do it, but it's very doable. It's done in countries around the world, and it's been happening in this country at a very low level for years. Recent efforts over the past couple of years, Breed and her team have really expanded it, but there is so much more opportunity to expand it. So that's on recovery. I want to say a couple other words about recovery, so I'll leave that aside for the moment because you're going to spend a lot of time talking about it today. But just say, to me, one of the most important transformative things we can do with the infrastructure in the NHS is to do a better job connecting all the people who are caring for patients so that they are all literally working off of the same page. But here I mean web page or EPR and not paper page. I've worked in a system where when social care, secondary care, and primary care are literally working off of the same page, how extraordinary that is in reducing the friction associated with the delivery of care, that everyone providing a service to the patient is working off of the same page. And as I spend every Friday going around this great country, and the excitement generated by the nurses, physicians, allied health workers, when they can see what the other one is doing, and they show me those platforms, and they're really excited about it, because often it's new. It's relatively recently that they're able to see what their colleagues are doing. But I will say most of the systems I've seen are pretty clunky. It doesn't work seamlessly or frictionlessly across those different, traditionally organized silos of primary care, secondary care, and social care. We will be trying more and more to join them up. And the more joined up they are, the more continuity our patients will experience, or the citizens will experience, and the less friction in getting things done. And I want to say a word about the inequality side of this. Last Friday, I had the good fortune to visit the Jean Bishop Integrated Care Center in Hull. And apologies to all of you where I visited or have not yet visited. Whenever you call out one, you're immediately not calling out everyone else. But I'll just say that was my most recent visit, so I'm going to focus on them because they're top of mind. And I just want to say it was brilliant what I saw there. And let me just describe what they're doing to address both the recovery crisis and health inequalities. They're using data to identify the highest risk patients. They are then doing a comprehensive assessment at the Jean Bishop Center or in the patient's home virtually, and creating a management plan that delivers them the services they need connecting, not creating new services, but just connecting them to existing services, and providing those people with an acute care alternative. This is done in tight collaboration with the local GPs, with local secondary care, the local emergency room, local police and fire, and ambulance conveyances. And in fact, they've reduced conveyances because if it's one of their enrollees, the ambulance will call them. Got a solution to the patient's problem without conveyance to the ED. This was exactly the kind of integrated care we need. Now, their IT systems they had aspirations for better. They were doing well, but could get better. So I just wanted to highlight that as sort of moving upstream, and moving upstream in the care process is going to both address our recovery efforts by reducing the need for hospital beds, but also addressing health inequalities. So it was really impressive to see what they're doing. And I know I've seen lots of other impressive examples around the country, so I just highlight that one. And then I'll just finish up by saying all of this work has a lot of challenges. Our digital infrastructure is not where it needs to be. We still have about a third of trusts in this country don't have an EPR, or have a semblance of an EPR, but not a true EPR. It's really hard to do all this transformative work with data if the information isn't digitized to begin with. And so I'm picking up now on the expression from NHSX, which I rather like, which is digitize, connect, and transform. And while it doesn't always happen like in that order, those are three things we need to do. And so on we do need to digitize more, and we have a big effort underway to level up the EPR base in this country. The second thing on that list is connect. Lots of great efforts on connecting, but just in the service of the delivery of care, we have this huge opportunity now to connect across an ICS. And so it says, what is an APR? And I think I'm saying I should be saying EPR, so I apologize if I said APR, but it may just be my American accent. We call them EHRs in the US, so I'm still tripping over the use of EPR. So on the connect front, lots of great efforts on connecting, but there is so much more we could do. And that's a whole topic in and of itself, so I won't go there. But we need to do more, and we will do more to connect so that the people delivering care and the people organizing the delivery of care have access to the data they need, the patient care record data for delivering care, and the extracted planning and performance information. And that leads me to my last point, which is for effective transformation, you have to actually measure the extent to which you are succeeding at the quadruple aim. So I love the fact that Breed and others, Laura, that you started off with that quadruple aim, because you have to keep coming back to that and say, are we actually fulfilling our goals with, for example, a home hospital virtual wards on that? And it's actually, just because you put a service in place and you are satisfying patients doesn't mean you're actually addressing all of the quadruple aim. And I've seen time and time again where you put a service in place, patients love it, providers love it, but you're actually adding service. You are not, in fact, replacing service. And we need to make sure that we are substituting more customized, lower cost services for cookie cutter hospital-based services, because that is the only way we're going to get out of this capacity crisis. So, and that is a non-trivial challenge that will require real-time data that allows us to compare ourselves across this country. So we have a huge opportunity here, but we're not there yet. So I really look forward to going on this journey with you. Thank you for inviting me to speak. I apologize that I can't stay. Actually, I have to go to a board meeting right now. But best wishes for your day today. And I really look forward to hearing the summary. So thanks, Breed.
Thanks, Tim. That's really helpful and lots of food for thought. And I think it fits nicely into the thread of the day. So we'll definitely brief you on how it all goes.